68% of Britons say they would support a 1% income tax increase if it was guaranteed to be spent on the NHS. 17% say they wouldn't support such a tax rise. Well, joining me now throughout the programme is Professor Dame Sue Bailey, Chair of the Academy of Medical Royal Colleges, Niall Dickson, Chief Executive of the NHS Confederation, and Dr Claire Gerarda, GP, former Chairwoman of the Royal College of GPs. Well, great to have you and your expertise gathered here as we go through this hour. Claire Gerarda, I want to talk with you. I mean, I want to get it all from you, just that overview about this crisis in the NHS. Is, you know, we've all talked an awful lot over the last few years about various crises in the NHS. Is this one different? Is this one bigger? Is this one more intractable? It's
certainly bigger. I mean, the programme you've just said on mention my profession, general practitioners, who are
we get on to that.
Who are really at the tipping point of being able to deliver to a greater number of patients, to a greater degree of complexity. It certainly does feel, and I've been in the NHS now for 30 years working in it, it certainly does feel a very different level of problem. The morale within the NHS of all the staff, the patients queuing up, the time that actually we have to be able to care for patients, and also the other end, the social care and the lack of social care, is all adding up actually to a serious crisis.
Okay, I mean, you touched on a lot of points that we are going to explore in more detail as we strip out the issues during the course of this hour. But Neil, your overview, and you've seen the NHS from many different perspectives, I know, over the years. This time, is it different?
Yes, I think it is different. I think the level of pressure which staff are experiencing across the health service is greater than it's ever been. I think the issue we've talked about for an awful lot of years, which is about elderly people who have lots of different conditions, who then find themselves in crisis within the system, I think that has reached a tipping point. I mean, just the volume which the system is trying to cope with at the moment is unprecedented. And I think that the system itself, which I think you can certainly argue is underfunded, and as Claire points out, social care in particular is a car crash. I mean, it really has gone from a really rather limited service to one that in many cases is simply not there at all. That's having a knock-on effect
agreement
as well.
There, and as I say, we are going to focus on that a little bit later in the show. But would you go along with this analysis, Dame Sue?
Yes, we've got an exhausted NHS system with exhausted staff wherever they work across the system. And we've got an obvious thing we need to do, which is to put money into social care. Transformation of step-down, step-up care for the frail elderly, so they can get which is to have appropriate supported care in their own home, and that's what we need to be able to offer.
Just want to throw into this, I mean, we've done a variety of surveys, as you know, lots of facts and figures going around, but obviously the public attitude is important, and, you know, you've all touched on funding. Again, we're going to look at that in more detail, but just that in this poll I mentioned there, where there's a lot of support for a hypothecated increase in taxation, one dedicated to the NHS. But would 1% on income tax actually do it?
I don't know whether 1% would do it. I suspect it would certainly add.
Calculations 3 or 4 billion you raise from something.
3 or 4 billion, well, a tiny chink. But I think increased money is the answer. We talk about efficiencies. I think we probably have the most efficient health service in the whole world, and that's not just me saying it, that's independent studies. So we get more for our money than any other health system in the world, and we actually get more because it is publicly funded, delivered through public servants. So more money is important. I also think there are other ways of raising that money.
As I say, I just want to go around the whole panel again. Neil, I mean, is more money obviously important? But we hear that, you know, there's an awful lot of money going in. Is there room for more ways of doing things better?
Yeah, I think there are lots of ways of doing this better, and I think with the existing money, but that's not to say more money isn't needed, because I think the current pressures are such. I think the difficulty of moving towards a better and more efficient system, and I think that there are better and more efficient ways, it is about reorientating the service more towards trying to support people in their own homes as opposed to having just to treat them once they get to the hospital end. Getting there itself does require funding, and building up new services while the old ones
And more GPs.
Dame Sue, just, I mean, the overview from this snapshot, this survey we carried out, the public are terribly pessimistic about the NHS, aren't they, really? They think it's going to get worse and the government's to blame.
I think the blame game is really not helpful, and what we've got to do is to put more resourcing and more funding to run two horses down the same track. One is to deal with the crisis we've got ourselves into, and the other is this transformation that's needed, and it's that we need to focus on, and we want this to be a depoliticised debate. It needs to be an informed discussion with the public, looking at 4 generations in every family now, what it is. Do they really want to have good health for as long as possible across their life? And we need to have this discussion with the public. We're
going to have that discussion a bit more, in much more detail, particularly on this issue that you've all identified. And thanks very much indeed for setting your stalls out on social care, the relationship with health care. We'll get to that in more detail a bit later in the programme. So stay with me, please. Well, still got my panel with me to discuss all this. Professor Dame Sue Bailey, Chair of the Academy of Medical Royal Colleges, Niall Dickson, Chief Executive of the NHS Confederation, and Dr. Claire Gerada, GP. And let's dive in on the funding and start with you, Dame Sue. Both ends of it, the reasons why and the funding. Can we start with the funding and thinking the unthinkable? Some people are saying, it's not really been said by politicians, some people are saying if we pay for eye checks, for our teeth being looked after, why can't an element of charging be brought into the mainstream NHS?
I think that's a discussion to have, but on behalf of all the doctors I represent, we want health to remain free at the point of access. We think we can reduce waste, we think we can improve performance, but we would not be looking to asking people to pay for their health care, because we know when that happens, the most vulnerable suffer. And you mentioned dental costs, and we know the state of children's teeth at the moment, so I think we need to learn the lessons. But we do need a discussion with the public that's informed and actually tells them this is what we can do, this is what we may be able to do, and what is it that you want for your family for health care. And we've already had an indication that many people would be willing to pay increased taxes.
But what about, on that point there, and, you know, Dame Sue's very clear about it, but, you know, and added into it is a discussion about insurance in some form. A lot of people have private healthcare insurance. Why couldn't that be used within the NHS to keep the overall funding envelope, but those that can afford it pay a bit more?
Well, the question is whether you're going to break the principle, and you can argue in a sense that dentistry and so on has eroded it a little bit, and prescription charges in England, though not in other parts of the UK. So you can argue it's a little bit is encroached, but the fundamental principle that it is free at the point of delivery is one which I think an awful lot of people in the NHS value enormously, about their relationship with their patients and their wider relationship with society. So I don't think within the service there would be much enthusiasm for that. But it is a wider public debate, as Sue has pointed out. I think that it's a perfectly legitimate one if people want to have it. It's also a legitimate one to have a discussion about whether people would be willing to pay more taxes. I think your poll seems to indicate that there is enthusiasm, at least among some people, not enthusiasm, but at least a willingness to pay more for if they can get a better service in return. I think when we get these funding pressure, and of course this is not the first time we've had a funding pressure, we've talked about how unprecedented it is in terms of the pressure that staff and indeed patients are feeling, but it's not unprecedented to have a funding pressure. And when we do that, we do tend to have a discussion where people start to say, well, should we start charging and all the rest of it? But I don't think the fundamental argument changes.
Okay, Claire Gerada, I mean, you know, it has been floated, I've been reading in the papers over the last couple of weeks, groups of GPs clubbing together to charge in their downtime, and indeed then, or discussions of fining patients who don't turn up for appointments.
Sadly, the inevitable consequence of what's going on will be a three-tier health system, a very expensive one for those who can afford. We'll have immediate access to a GP. You'll then have the middle tier of GPs working with hospitals, and then you'll have the uninsured, or the sort of the ones that where you have no money, you queue and basically not get as good a service. So I think inevitably, unless we get increased funding. But going back to your question about more money and how to raise money, there are different ways. So, for example, national insurance, when you reach reduced premiums when you reach the age of 65, and many people over the age of 65 are still working, still earning good money, you don't pay any national insurance. We've got an equitable system where the young are actually paying far more than the wealthy elderly, such as myself, who have had all the benefits. You've also got other things that you can do. We may be able to introduce, politicians can, a social insurance, an insurance that you maybe start taking out in your middle years, which you continue to pay for, which actually pays for your social care when you need to draw down and it's in your 70s, 80s and 90s. So there are other ways of looking at this other than a co-insurance or additional co-payments, which, as the others have said, will just penalise the poor and the sick.
OK, well, we've used up this chunk of time. I'm afraid we will get to that very issue. It seems to be underlying most of the discussions we've been having this evening of social care and its relationship with healthcare in the next part of the programme. And Claire Gerarda. And Claire Gerarda, you touched on this in our first discussion in this hour, the problems caused by social care, its relationship with healthcare. The cry must go up and say, well, why can't everyone, every trust, do it like Torbay?
Listen, I'm a GP. Most of my home visits are to visit the elderly who have very little social care, because in the end, people will have to go to their homes. In the end, you will need Meals on the Wheels. In the end, you will need a carer to wipe your bottom. In the end, you will need somebody to put you to bed. So whilst these integrated services are fantastic, in the end, that patient will have to go home. And most of my day is spent trying to pick up the pieces of elderly people who have nobody to look after them, who might have 15 minutes or half an hour of a carer going in, doing a very brief bit of care. They want to do more, but they can't afford it. Social services can't afford it. So unless we deal with the social care issue, the budget around social care, most of the other, I'm afraid, is just papering over the gaps. And whilst the Torbay experiment is fantastic, absolutely fantastic, in the end, the patient will have to go home.
The problem continues elsewhere.
The problem continues.
OK. Well, I mean, in terms of this long-term problem, and we all know about the demographics, well, we had a report, didn't we? We keep hearing about reviews and more commissions, but we had Sir Andrew Dilnot, yes, 2011.
Yes.
I mean, I've reread that, and you obviously understand it much more than I do, but it seems like a lot of the solutions are there. It's oven ready.
Yes.
Well, the Dilnot review looked at how you should fund the system. I think the problem that we've got at the moment is actually much more basic, which is that there is very little funding going into the system at all, and that public funding is inadequate as it currently stands. So there is probably a longer term set of solutions. Dilnot wasn't the first. There was a Wanless Inquiry Commission,
yeah.
but the King's Fund when I was there.
But the point is, don't we have to grasp the nettle now and say we will get this money, and these are some of the suggestions, and that's what you've been talking about, Dame Sue, the public buy-in. But the politicians have to buy in first and put it before the public.
No more analysis, no more data, no more commissions. We have to have a public debate with every family in the land. What value do we place on the health of the nation? And without a healthy nation, whatever that variety of issues is, whether it's neonatal, whether it's care of the elderly, whether it's good care for long-term conditions, we have to have that discussion, and that needs to take place for the first time ever across the political divide. And that really is what needs to happen.
Well, it did get discussed across the political divide, but it was before a general election. And one of the parts of the discussion, and this is about charging, is for long-term care, that people can afford it. Where should the cap be when it comes to using their assets to pay for it? Neil?
Well, I think that discussion
that has to be had.
That has to be had
again
between. But actually, the idea of getting the political parties to come together at the moment looks extremely difficult, I have to say. We would like at least some consensus about the fact that there is a serious crisis in social care and that there is a real difficulty within the health service. And the reason why even people from the health service talk about social care is it has this knock-on effect on the healthcare system, as you saw. And I would like to say, though, around this question of integration, that I think that it's not a panacea, as Claire says, but actually in large areas of the country, the system itself is not well organised.
That's what I wanted to get back to Claire about.
And it could be better organised if you had integrated services. That is extremely difficult when the funding is tight.
Well, how does it work with you?
Well, we had more.
Do you feel you could be more integrated?
We had more of the future 15 years ago.
Really?
We had intermediate care hospitals, we had integrated health and social care, we had our own social workers, we had our own beat officers coming to our meetings, we had a community liaison worker, we had elderly care community psychiatric nurses. We had more of the future 15 years ago. Now our community hospital is being closed down, the health visitors and the district nurses have all been dispersed, we no longer have a community liaison worker. So the solutions are there. As you said, it's off the shelf. We have it. If we stop photographing it, as Sue has said, and started putting action and stand still long enough so that we can make the relationships.
I just want to get your feeling on that, on what Claire's talking about the past and the reasons for it. Is it to do with funding cuts, or is it quite a lot of it to do with bureaucratic reorganisations that have taken place over the years and, you know, just rearranging the deck chairs?
They've not helped, and often where innovation has come in, it's coming through adversity. We've had to get something right, so people have got together and done it. And then they've forgotten that that's actually a solution, and they've gone back to the day job. We need some headspace, and Neil said it would be difficult to get cross-party commitment to this. Well, my challenge here and now is without that, we jeopardise the health of the nation, and I would like politicians to stand up and be counted and get on with it.
It's not going to go away.
I just want to throw in here, I mean, in terms of the shorter-term solution, you know, something that I know I've reported on again in the past, it's IT. Billions have been wasted within the NHS on trying to integrate that. That clearly would help in this day and age. You know, I've got personal experience of family members. You know, we've all had it, haven't we? They're somewhere else, they get
lubricate
lost.
the system. It would lubricate and it would help, but fundamentally IT isn't going to wipe your grandmother's bottom.
No, but in terms of that integration.
Yes, integration does help, but what really helps with integration is shared working, is joint working, is me knowing you over a long time, so I can build up a trusting relationship. And having the time. That's where it's joint working that goes beyond letters, beyond case notes. If we get integration with access to community beds, then actually we can start to move the system on. And we need a non-means tested care system, because if you've got a non-means tested health system and a means tested care system, well, you're also a non-starter.
I get the sense we're getting a consensus here, and it's not rocket science, isn't it? We're looking at the NHS spending so far today, 317 million and rising, gone, that if we get that right, we're getting close to the solution.
I also think we do have to get some of the payment systems aligned. At the moment, we pay, for example, for hospitals by activity. We need to have a system which bases it on the outcome for the patient, irrespective of where the patient is. And
Well, that gets back to the past, though, isn't it?
Well, again,
it was about outcomes.
Yes. It has to be about outcomes, and of course we are better actually at measuring outcomes now than we were in the past. So there is a real opportunity there.
So, I mean, so we're back to politicians meddling.
But it's just at the point where we're getting there in terms of, you know, eventually data will connect. We mustn't give up on that. Eventually we have been able to move from outputs to outcomes. So we're just at a point where it's right to all fall into place despite all the problems. But this takes politicians to actually do what doesn't come naturally to them, which is to come together for joint cause for the health of the nation. Because the health of the nation is also, post-Brexit, about the ultimate economy of the nation.
Absolutely.
So it has to be done.
Got to end it on those words. Thank you all for being so illuminating and sharing your thoughts.
Well, Dr. Howard Freeman is in our central London studio. He's Clinical Director of NHS Partners Network, which represents independent providers of NHS clinical services. Members include both for-profit and not-for-profit sectors, and include large international hospital groups and small specialist providers. So, Dr. Freeman, how do independent providers fit into the NHS? What are the kind of services that they provide?
Well, good evening, Ian. Independent sector providers provide services across the board. They provide community services, hospital services, NHS 111 services, all free at the point of delivery to NHS patients and at the same standard that other NHS providers deliver those services. Last year, 10 million NHS patients were treated in independent sector providers. 500,000 surgical interventions were done across 2,000 sites, and that cost about 6.8% of the total NHS budget that we saw just before.
Could the NHS function without these independent providers?
Well, we add capacity to the NHS, and right from 1948 began The NHS has worked as a partnership of NHS-owned providers and independent sector providers. If we think about dentists, pharmacists, hospices, they've always been there in the NHS. And certainly when the acute sector is under as much pressure as it is now, I think it's unlikely that the NHS could provide services to patients with waiting times, even as they are now, without the support of the independent sector.
Now, one of the big complaints that we frequently hear, particularly from the unions and the Labour Party, is that these independent providers are somehow in competition with the NHS. Is that actually true?
No, it's not true. We call ourselves the Partners Network because we partner NHS providers. The NHS just does not have the capacity to deliver all of the work that it needs to do in NHS-owned providers. And so it has to deliver some of that work in non-NHS owned providers in the independent sector. And indeed, we take pressure off the sector. We innovate for the sector. One of our members, Healthcare at Home, has got a virtual ward which it's run for about 20 years now for 19 acute NHS providers, where patients can phone up, get advice 24 hours a day from a healthcare professional, which means they don't have to go into hospital. So we actually support the NHS in a huge number of ways.
So why is it, do you think, in that case, that you're not in competition with the NHS? The NHS couldn't survive without some level of independent provision. Why is it that the healthcare unions have such a downer on independent provision?
Well, I can't speak for the healthcare unions. The unions have their own views. As I've said, the NHS has worked in partnership with independent sector providers right from its inception. And if this is privatisation by stealth, which I've heard the unions claim, it's a very long process, isn't it? If by years after the NHS started, we're still only at 6.8% of the budget. It's going to take several lifetimes if it is privatisation by stealth.
Well, surely one of the problems is that whilst government spending is roughly in line with advanced country averages, it's the amount of spending by private households on healthcare that's way below the international average. Is that something that we need to think about, more households stumping up more money for themselves?
Well, I think that's a big political issue, isn't it? That's something that we as a country have to debate, and it's something that the government or the opposition parties have to think about. I think what's happening now is that the NHS is seeing the effect of the demographic changes, the fact that doctors can provide more and more treatments, fortunately, which keep people alive longer, and those treatments are much more expensive. So we as a nation have to decide how we want to spend our money.
All right, Howard Freedman, appreciate you joining me. Thanks very much.
My pleasure. Thank you, Ian.